Hi, I'm Bev Miller, and welcome to Addictions Unplugged. Each week, my co-host, Dr. Vera Tarman, will answer your questions and concerns about addiction. Tonight, we're going to be discussing addiction to prescription drugs. Medication is supposed to help you, but ironically, it can frequently be harmful. It can start quite easily. Pain pills for your back, sleeping pills for the occasional sleepless night, or perhaps stimulants to help you focus before a big exam. Are you worried you might be addicted to your prescription drugs? Call us with your questions and concerns. Now, Vera, I think that many people would be surprised to learn that addiction to prescription drugs is indeed a real concern. It's a real problem. So my question is, what are prescription drugs? Give us an overview.
Okay, well, prescription drugs can mean pretty well anything from aspirin to antidepressants to, well, just prescription drugs. But when we talk about concern for abuse, we're really meaning three major categories. We're talking about prescription drugs to narcotics or pain pills, what we classically call opiates. And that would be anything from Tylenol 1, 2, 3, 4, to Demerol, to morphine, to OxyContin. They're all the real heavy-duty pain medications. They're like top on the list of what we're concerned about. But we also see addiction to sedatives, sleeping pills, anti-anxiety medication. And that can mean anything from Valium to clonazepam to temazepam, all of the PAMs.
All the PAMs, yeah.
That's right. So those are the sedatives, and they are the next category of major abuse.
Okay.
And then third on the list would be stimulants, and that's typically what's given for ADHD or I mean, it used to be actually given for diet, like to go on diet.
That's right. We've done that in the hospital.
Help people stay awake, like truck drivers staying awake at night. But now predominantly it's used for ADHD.
Okay.
And that is third on the list of potential drugs that have been abused. Yeah.
Okay. Are you worried that you're addicted to your prescription drugs? Give us a call and share your concerns and your stories with us this evening. There are certain groups that seem to get certain prescriptions. Can you talk a little bit about that?
Yeah, well, we could probably see in those three major categories, and there's other ones that you can abuse. Like, believe it or not, you can abuse antidepressants. You can abuse other medications like antipsychotics. They're all game for abuse. I mean, and then there's also the kind of abuse where people get prescribed, sell them essentially for a sort of second income, and that can be like even medication for cholesterol, high blood pressure. It doesn't have to be the psychotropic drugs or the ones that affect the, your mood.
Right.
But those are the ones we're worried about because that's where the abuse potential is.
Okay.
But we see that there are some groups that are more vulnerable for prescription drug abuse, and number one on that list would be the youth. And it's not so much that they're prescribed more, but they tend to have the negative consequences more. That's what we worry about because they're, tend to be a population, that are more using medication at more risk.
Okay.
And
is it their bodies aren't fully formed as yet, so it's easier to harm them?
Well,
what is the?
It's true. Their brain is not fully formed because they're at a sort of peak in terms of cognitive development, especially when the person's a teenager. But there, it's more just they don't have the sense of what's dangerous and what's safe.
Okay.
I mean, they're really playing with that boundary, and we're dealing with drugs that can be quite dangerous. And if they're stuck doing that, they're not learning appropriate boundaries and safety mechanisms. But in terms of physical consequences, one of the areas that can be quite concerning for seniors because the older you get, the less likely you are to metabolize the medication that you're taking.
Right.
And where you're used to taking 2 every 4 hours, you really should be just taking 1 every 4 hours, for example, just whatever drug it is. Therefore, if you're actually abusing that, you're at more risk of getting overdose or secondary consequences. But there's women tend to be prescribed more antidepressants than men are, so they're more at risk there. So I mean, there's different age groups where there's different vulnerabilities. Put it that way.
So how does one become addicted to something that's supposed to be helpful?
That is the million-dollar question.
Yeah.
Yeah. I mean, you could ask, when we say prescription drugs, the main thing that's different about a prescription drug is it's prescribed by a doctor.
Right.
And so therefore it has the stamp of approval, the stamp of safety. And even if a person is taking a medication the way they're supposed to, like let's say it's a Percocet for tooth. You got your tooth, or you got a wisdom tooth pulled out, and for 3 days you have to take, one Percocet or 2 every 4 hours. Even if you take that properly, there's a good chance if you take it after a period of days that you will become not addicted but dependent on it.
Dependent.
And dependence is different than addiction. A person, anybody and everybody could become dependent if they take a medication daily, continuously for a certain number of days.
So are we set up for this? Is it a great setup?
Well, it's a great setup to become dependent on something if you're on it long enough.
Okay.
And there are actually indications that doctors are given about you do this for this period of time, and then if you're going to go beyond that period of time, in other words, where you might become dependent on it, your patient will become dependent, then you have to start weighing the risks and benefits.
Right. Do you feel that you're dependent on your prescription drugs? Are you addicted to your prescription drugs? Give us a call this evening and tell us your concern or your story. So you carry on with that then.
Yeah, so that you might become dependent, but that still doesn't mean that you're addicted to it. It just means that when you stop, you're going to have the consequences. And there's probably a lot of people who have been on, like they've had their gallbladder taken out, for example.
Okay.
If you're taking your opiate medication, which is like Tylenol 3 or Percocet or something stronger, after a couple of weeks of taking that regularly, you're going to feel sick when you stop. That's the withdrawal.
Yeah.
But if you're new to the whole experience of taking opiates, you might just think you had a bad flu. Oh, I got the flu.
Okay.
I got the 3-day flu or the 5-day flu, or geez, this flu is taking a little longer than normal.
Interesting.
But you don't recognize, oh, that is actually withdrawal. Still doesn't mean you're an addict. The addiction is when the person is getting that extra benefit of, I like this feeling, and you know what, I'm only supposed to be taking 2 of these every 4 hours, but why not take 3?
Oh, okay.
And it's supposed to be 4 hours, but it's only 2 hours, but I'm already feeling the pain, so maybe I'll take a little more. You start taking more than you're supposed to, and you run out earlier. And when you start doing stuff like that, that's when it's moving into the realm of abnormal behavior around the drug, and that's when we start to see an addictive pattern.
Right. Are you taking your medication safely? Give us a call. Give us a call. Actually, we have a caller. Danny, hi.
Hello.
How are you doing this evening?
I'm good, thanks.
Good. What's your question or concern, Danny?
Well, when I was a little bit younger, I was in an accident at work, and I was put on OxyContin
Yeah.
for a prolonged period, and then the doctor advised me to go to a methadone clinic.
Okay.
And the methadone clinic allowed me to go up as high as I wanted on my dosages. I was up to 185 milligrams. I've been on it for 10 years, and they don't tell you to come down. They don't
Okay.
advise you. They just let you do whatever you want.
Danny, let me just ask you, how long were you on the other drugs, the OxyContin? You said
For about a year. I
for about
started with the Percocet,
yeah.
and then the OxyContin, and then my doctor sent me to a methadone clinic.
Yeah. Did your doctor want to take you off the OxyContin, and you found it hard to get off of them?
Yes.
Yeah, because that's often what happens for the viewers. People are. I mean, actually, Danny, your story is pretty typical for people who get on methadone. They start on a short-acting drug like Percocet, and then they end up on OxyContin because it's you develop a tolerance, or like I was saying a minute ago, dependence, and then you want to get off of it, but it's hard to get off of it. So then what we do is we offer methadone. But you say you're on 180 milligrams, eh?
Yes, they did.
And have you been trying to get off, but you're saying that you're having a hard time coming off of it?
Well, it's even more addictive than the OxyContin.
Yeah.
It's harder to come off.
Yeah.
And I also know a lady that is prescribed OxyContin, and she's been on the same dose for over 15 years.
Really?
And they will not raise her dosage. They will not help her out at all anymore.
Uh-huh.
So
Yeah.
sometimes she's in so much pain that she has to seek other stuff elsewhere.
Right, right. Well, you know, the problem with those sort of long-term pain, I mean, you develop a tolerance, and it only works so well. And one of the things that we've discovered when people have been on drugs like that for a long time is that they become what we call hypersensitive to pain. Their pain actually seems to get worse. But there's only safe-wise, the safety margin, generally speaking, you don't want to give the person too much because it's going to make them too sedated, too constipated. Like, we're kind of dealing with a rock and a hard place. The pain, you can only treat it so well, and then you've got the consequences. But Danny, I'm interested in your question about the methadone.
Yeah, the methadone, like I was saying,
Yeah.
the doctors there, they don't put any limits on you. There's no capping off of how high you can go.
Well, actually,
Now,
yeah.
like just recently, they made some new rules. But
They have, that's right. Are you living in Toronto?
yeah, I'm in Scarborough.
Yeah, okay. Because you're quite right. There used to be with methadone, and methadone, for people who don't know, that's the sort of opiate substitute that you would give somebody who wants to get off of OxyContin or Percocet or even heroin. This is considered a safer drug to help wean a person down. And you're absolutely right. There was a time when there was no cap, and people were on like 200, sometimes 300 milligrams, which is really high. I mean, if they had a bowel movement, it was like 3 weeks ago. They were so constipated, and you know, drowsy all the time, and forget about having any sexual interest. It just wipes out. But you're right, Danny. What's happened is that they've cut down. They've said 120 is the maximum that we should give somebody, and if you have to give more, then you have to actually ask for a second opinion from another doctor. So have they been trying to get you down from the 180?
Well, I came down myself.
What are you at now?
I came off from 180 at cold turkey.
You mean you just got off of it?
Yeah, I jumped right off to zero, cold
Wow.
turkey, in a rehab facility.
Okay. Boy, how
And,
long did that take?
About 4 months.
Yeah. Wow.
And I was still having withdrawals after 6 to 8 months.
Oh, yeah, yeah. I mean, you said that methadone is harder to get off of. It's actually not harder, but it feels harder because, you see, the thing about methadone is you only need to take it once in a day, so it has what we call a long half-life.
Okay.
Whereas a Percocet's 3-4 hours, and so you need to take it a bunch of times in the day. But that means that the withdrawal is long. Like, Danny, 4 months, that's long, but I've heard that before. Whereas if I was trying to get off of OxyContin, it might not take that long. It might take a month. So it's, you know, you get the worst of it over and it's quicker. But actually, opiates are one of the hardest to get off of.
My goodness. Danny, that's congratulations for
Yeah.
getting yourself off of that.
Yeah.
Quitting cold turkey like that, that takes courage. That takes real courage.
Thank you.
And
Yeah.
Danny, we just want to thank you
Yeah.
for calling this evening. Thank you so much for watching the show. We're going to be going to break in a little bit. Is there any last thing you want to say to Danny?
Well, Danny, I would say that you haven't actually said what you're doing now in terms of if you've got any pain, but be careful to not abuse the opiates or take them more, because you're kind of a sitting duck to become dependent on them again. So just be really careful.
And
Congratulations for walking away
Yeah.
from methadone. It's a very hard drug to just walk away
Absolutely.
from. Usually people taper right down.
Exactly.
Yeah.
So that was really courageous. That
And
must have been difficult to actually do physically.
Oh yeah,
and
because
the
at
symptoms.
180 milligrams, usually that takes about a year to get off of.
Wow.
Comfortably, and he just walked away. So yeah, wow.
More power to Danny there. Well, we're going to be going to break, and we'll come back with more information about prescription drugs. But we'll be back with more help on Addictions Unplugged. Welcome back to Addictions Unplugged. I'm Bev Miller, and joining me each week is my co-host, Dr. Vera Tarman. Today we're discussing and taking your questions on addiction to prescription drugs. Have you become addicted to your medication? Give us a call with your questions or share your personal experiences this evening. We've got Lennox on the line. Lennox, are you there?
Yes, hi, how are you?
Hi there, great. How are you doing?
Good.
Super.
Thanks for taking my call.
Absolutely.
Yeah, so the reason why I'm calling, I was suffering with depression for a little while now, the past couple of years. And I've been on 300 milligrams of Wellbutrin. And alongside with that, I was on 2 milligrams of clonazepam.
Yep.
So I decided that I wasn't benefiting anymore, and I came off of the Wellbutrin. Everything seemed to be fine. I did it over a week. I cut it in half.
Yeah.
So I took it down to 150 for a week, and then finally nothing.
Okay.
But I realized that clonazepam is more of an addictive drug. So I want to come off of that as well. I don't trust my doctor. I think he's a pill pusher. So I want to know how safely, or is there a safe way to come off of it?
Well, okay, so first of all, Lennox, I'm going to say that I can't actually advise you specifically about what to do, but let me speak in a generic way and you can take from that, okay? Just because I don't know your history and it wouldn't be right for me to do that. But I'm going to speak in a general way. In a general way, coming off of a drug like Wellbutrin, I mean, there's not really an addictive profile with Wellbutrin, although you can actually abuse that drug, and I'm not going to tell you how to do that because I don't want to, give those that kind of information out to the audience. But to get off of that, we usually ask people to do it actually in the way that Lennox did. Cut in half, maybe every week or 2 weeks until you're off of it. And it's even if you stopped it abruptly, it's not bad to do. Although you can actually get withdrawal, believe it or not, from antidepressants. I mean, people don't know that, but you can actually get what's called reactive depression or reactive anxiety. And what does that mean? That means that not that you're actually really depressed or anxious, but that you're getting a physical withdrawal that mimics depression and anxiety. So we usually like to, I mean, Lennox, one of the things that you did that is probably not a good idea is you're trying to do it on your own. And I appreciate that you're saying that your doc, you don't really trust your doc. But you see, the thing is you want to be under the care of a doctor, somebody that you trust, so that they can say, you know what, I think you're getting depressed, and maybe you need to slow down on the taper so that something doesn't happen. But anyway, you've already stopped that one. Clonazepam, just in a general way, is much more, remember I was talking about the tolerance?
Right, yes.
You can develop a tolerance to clonazepam in a way that you don't with an antidepressant. And absolutely the withdrawal to any of the PAMs, the benzodiazepines, can be murderous. And we would generally say that you want to slow that taper down if a person is on 2 milligrams, I would probably do 1.5 milligram, every week to 2 weeks, maybe even 3 weeks, depending on how much the person's willing to feel a little bit of agitation. Then to 1 milligram, then to 0.5, and then down, maybe over the course of a month to 2. And I mean, Lennox, what was your experience when you tried to come off the clonazepam?
Well, that's the thing. I kind of looked on the internet first, and I realized I researched that clonazepam is a very addictive drug. I didn't know that.
Yeah.
And they say that you can have seizures and all kinds of things, so it really scared me, right?
Yeah, but I mean, just to clarify, you're right about that. But usually it's at a dose that's a little higher than what you're on. Like it's usually depending on if you're on another medication too, right? But usually we're talking about something that's 4 milligrams or higher. So at the dose that 2 milligrams. Again, I'm speaking generally, not specifically to you. The risk is not so much seizure; it's more just discomfort. And I don't know if you've had this experience, but the discomfort is anxiety, as I said. It could be that you can't sleep, like insomnia.
Right.
And the thing about benzos, unlike antidepressants, is they take a long time for those symptoms to go away. And even if a person is really determined to get off it, if you're not sleeping for 3 months, you end up saying, "Oh my God, just give it to me.
Exactly.
I need to sleep."
Yes, I've seen that happen before.
Yeah, because it takes so long. But I just want to correct one of the things that you said. You might not actually be addicted to it, but you are tolerant to it. You are dependent to it, and so you're going to have some withdrawal. Anyway, good for you for trying to get off of it. And can I make the suggestion, if you don't trust your doc, go to a walk-in clinic for over the course of a month. every week or so. And just don't do it alone, because you really ought not to do this stuff alone. Okay?
Yeah, I'll take you up on that advice. That sounds great. Thank you.
All right, but you're on the right track, I think.
Good stuff, Lennox. We hope we've answered your question, and thank you so much for calling. Do you think you might be addicted or, intolerant or tolerant to your medication? Give us a call and share your story with us. We have Leah on the line. Leah, are you there? Hi.
An interesting topic after your last discussion. I have been taking for sleep trazodone for the last couple of years.
Yep.
And I decided in my wisdom that I did not want to take this anymore. I wanted to sleep on my own.
Yep.
And I tried to go off of this, and a month turned into 2 months.
Oh my gosh.
Where I would be going 5 o'clock in the morning and I couldn't sleep, and then finally by 6 o'clock, when everybody's ready to get up, I'm going to sleep.
Yeah.
And it went into like the 2 month plus period, and I decided, forget it. Like, this is not worth it.
Yeah.
I'll take that pill. It's one pill, and I'll be able to sleep.
It was just the one pill, eh? Like 50 milligrams?
No, more like 100 milligrams.
Okay. All right. Did you just try to stop the 100, or did you try to break it up, like into 50 or 75 first?
No, I took the 100 milligrams.
And then when you went off, did you just stop, or did you try to cut down first?
I stopped.
Yeah. Okay. Well, given that it's so hard for you, you might want to consider cutting it down, like even to 75, and then to 50, and then to 25.
Yeah.
Some people actually with trazodone, it's actually not as hard as a benzodiazepine, but some people have a hard time, nevertheless. And it sounds,
really had a hard time with
it. I would suggest with you that it's good you went back on it, and now try on a much slower taper. Yeah.
So titrate it like just a smaller dose, bit by bit by bit.
Yep. Yeah. Now again, I'm speaking generically, because Leah, I don't know your story.
I understand.
But I think that would, in a general way, be a good idea, is to titrate it. You got to go with how you feel comfortable, because if you're back to using it again in 2 months, then you haven't gotten anywhere.
Right.
I haven't gotten anywhere, and I'm starting to sort of question, like, why don't I just continue and take it?
Yeah.
Because my sleep is so perfect when I'm taking it.
Right. Well, yeah.
But I'd rather not take a drug.
Yeah, that's right. I understand what you're saying. Well, I mean, at this point, you might want to go back and just stay where you are. I mean, like you're saying, why fix what's not broken? Or is that how we do that? All right.
Something
exactly.
like that.
Yeah.
We know what you're saying.
Yeah. But when you want to get off,
I'd call it sort of like a dependence on it.
Yeah. Well, I mean, it is. And it could even be a psychological dependence, and that's fair enough. And if you want to get off of it, like I said, consider the titrating.
Okay.
But also read up on sleep hygiene, like things that you can do instead, because you're going to have to change something else. You're used to taking this pill, and you've psychologically become dependent on it. But you're going to want to find a different kind of, basically, ritual that's going to help you fall asleep. Like, I don't know if you do teas, warm teas.
Yeah.
I even tried meditating, like the whole mindfulness.
Yes, absolutely. Pay attention to things like the sleeps, like the sun, the light cycle. Like if you, I'm serious, like having if you're watching TV late at night, like Roger's right now,
that affects your sleep.
Yeah, it keeps you awake. It's like something the light is telling your brain. It's still sunlight.
Masks, like I look like one of those Hollywood movie stars that wears the mask at night.
Oh, okay, okay. Yeah. But there's light therapy. Look into that. I mean, there's other things that you can do to help yourself along. I actually think that carefully using melatonin is another option. These are other ways that you can kind of naturally find your own rhythm again. But let me tell you that you're struggling right now, but it is possible to get off of trazodone. It is, like it really is. Even if you're having a hard time, you're just going to have to be a bit more patient.
Okay.
Yeah.
Leah, we hope we've answered your question this evening. We hope the doctor has answered your question this evening. Thanks so much for watching the show. Thank you so much.
Thanks for calling, Leah.
All right. Do you think that you are addicted to your medication? Are you taking it safely? Give us a call and let us know. We've got Bill. Bill, are you there?
Yeah, I'm here.
Hi, Bill. What's your concern or your question or story?
Well, the concern is for about 8 years I've been on Seroquel. Now I'm on the Quietapine, the generic.
Yep.
Originally I was around 700 milligrams.
Whoa, that's a high dose.
Yeah, and I've been able to scale it back to 400.
Yep.
Actually had a doctor tell me that I should be on 1600, which
Wow.
was ridiculous.
Uh-huh.
And that's a very influential doctor in the country. But anyways, I've been able to cut it back to 400, and then...
Are you cutting it back on your own or with the
yeah,
care
my
of...
doctor agrees that I could be on nothing.
Okay.
He's known me for 30 years. He's
Yeah.
seen me most of my best years on absolutely no medication.
Are you saying that the same doctor who said you can be on nothing is now got you on 1600 or 800 milligrams?
No,
Those
I
are
saw
two different doctors.
a specialist
Yeah.
who said that he wanted
Got
to
it.
increase it to 1600,
Whoa, okay.
which was kind of insane.
Yeah.
Anyways, the doctor I see is also a specialist, but
Yeah.
I mean, the specialist I saw is apparently the top guy in Ottawa. I'm not going to say his name.
Yeah,
but
no, that's fine. I appreciate that.
basically, you know, my guy's a specialist, and he says,
Yeah.
Rob, Bill, I've seen you on nothing
Yeah.
before, and basically, you know, his assistant Rob sees the same thing. That,
Yeah.
Rob says, you know, I've seen you on nothing for many years and very productive, but now because I've been on this stuff for 8 years and
Yeah.
I need it at night,
Uh-huh.
and I intentionally don't take the XR stuff because that's extended release, and
Yes.
I just need the stuff to get to sleep at night.
Okay.
I can't, when I hear people taking the stuff in the morning, I couldn't even imagine, because
Yeah.
it gives
Yeah.
you, many people that I've spoken to, it's like a big hangover effect
Yeah.
from taking it at night.
Yeah, Bill, let me just interrupt for a sec, because I want to tell the viewers a little bit about what Seroquel is, because what you're talking about is it's good for people to know about. Because Seroquel, if you don't know this already, it's really interesting, is the #1 prescribed drug in America and Canada. #1 prescribed. Even more than any antidepressants, even more than antihypertensives, lipid medication. It's the #1 prescribed drug, and basically it's an antipsychotic that's used as a sedative.
Right.
Now, in your case, Bill, was it being used because you had a psychotic episode at some point, maybe because of drug use or something, or was it just as a sedative?
A sedative, and
Really?
I'm told even the guys in the middle of the wars that are fought overseas are given this medication
Yes,
just
you're
so
right.
they can sleep.
When you walk into a jail, apparently it's one of the first things they prescribe to you for a night. I mean, in a sense, when you're talking about that kind of dose, it is a kind of, I'm sorry to say it, it's kind of like a chemical restraint.
I was going to use that same
Yeah,
word.
yeah.
It's a restraint.
Yeah, it's a restraint because,
Some
like you said, it makes you really dopey.
Some of them call it a sleeper drug. I know it's called other things
Yeah.
like antipsychotic, but some
Well,
of them just see it as no
It is
matter,
I mean, it's a great
no matter what you
antipsychotic.
are, or no matter what
Yeah.
so-called label, it'll make you sleep no matter who you are.
Right, that's right. So I mean, it's used for sedation when people can't sleep. It's used for when a person's got a psychotic break or episode or a manic episode, and they just can't sleep, and you just got to basically give them something like a horse It's not a horse tranquilizer,
Right,
but it's
but
that
it's-
effect when it's at that kind of a dose. I mean,
And
one.
then the other one I'm on is clonazepam
Yeah.
with bromazepam, so
Whoa.
2 milligram clonazepam and 3 milligram bromazepam tablets that I can use if
Wow.
I'm really totally stuck and I just can't sleep.
Well, you know what? And you still can't sleep?
Well, I can, but it's crappy sleep. I mean, it's
Yeah.
just not the same as the natural restorative sleep I used to get.
No.
And it also leads to weight gain and appetite.
It
and
absolutely does. That was the other thing I was going to say. And like you said, in the morning you wake up and you got this terrible hangover that probably lasts until half the morning.
Wow.
Yeah.
Yeah.
And it's a hell of a lot of willpower. Well, heck of a lot, pardon me.
Yeah.
To get just shake those cobwebs and get rolling.
Yeah. Yeah. But
and the amount of hours of sleep I need is way more than when I was on absolutely
Yeah.
no medication.
so Bill, it sounds like you got a doctor who's saying, look, you can get off of this and be fine without it, and you got another doctor who's saying, I want to put you up. So where are you now in this
Thing
process?
Put me up. He's no longer in the picture. I just said that's ridiculous.
Okay.
That would put me on a
Okay.
shelf, so to
Okay.
speak. I
So-
would be a zombie.
Yeah.
But basically, the doctor I see agrees I can be down to nothing,
Yes.
and I have gotten from 700 down to 400 on the Seroquel, but
Right.
I seem to have hit this plateau
Okay.
where if I go any lower,
Yeah.
I just don't sleep that night. Even I'm taking 25 ml tabs and cutting them in half
Oh,
with
really?
a pill
Yeah.
cutter.
Yeah.
And I don't know which of the two I should be reducing first, the clonazepam or the Seroquel, but I need right now both of them just to get
Yeah. Well,
8 years of addiction of this stuff.
Yeah, I would suggest that, no, I don't want to suggest. I would say to you that it's probably going to cause less disruption to your sleep if you come off the Seroquel or reduce the Seroquel rather than the clonazepam or the is it temazepam you said you're on?
Clonazepam.
Oh, clonazepam, yeah, okay. Because that one is definitely a sleep disruptor. I wouldn't try to get off both at the same time. I mean, your doctor, the one that wants you off of everything, or at least believes you can be, would probably say don't do both. I appreciate you're saying that you're kind of at a standstill, and you might have to, I don't know, maybe are you okay with where you are right now?
Oh, it's just way inefficient sleep, huge hangover.
Yeah,
it's just
so you're still not
impacting
happy.
My quality of life way too much.
Okay, so would you be willing to, with your doctor, maybe start to cut down on the Seroquel very, very slowly and accept that you're not going to, you're going to have a few sleepless nights, because Seroquel doesn't take as long to readjust as clonazepam does.
Okay, well, I'll suggest that to him.
Yeah,
And,
yeah, but don't do it on your own, seriously. You know, sleep is such a, it really changes us when we don't sleep. And you want to try to, you know, you've got a goal to get off of this, but you also want to live your life one day at a time in a decent way.
Absolutely. But are there some, some of the other things that you were talking about, some of the more natural things that might help in the meantime as well?
right,
Like,
right.
exercising every day and
For
getting
sure.
sunshine, because when we're out in the sunshine during the day,
Yes.
that helps to create the melatonin and such that we need to sleep at
Exactly.
night.
Yeah.
And warm shower or warm bath,
That's right.
some hot milk or hot soy milk or something.
Because you know what?
Would these help
for
too?
Sure, because one of the things that happens when you're on so many medications is you forget that there's a natural rhythm of the body, and we're using pills to essentially try to mimic that. Bill, I don't know what your story is in terms of that, but I really want to suggest that if we don't get in the way of ourselves, our body wants to sleep.
Right,
It wants to sleep properly. And it's a matter of learning what are the things I need to do to get myself in my natural rhythm. So like you said, the exercising.
Exercise is powerful.
So that you get tired.
Absolutely.
Using light, because we are animals that, we've got the pineal gland, which monitors our melatonin according to light.
Exactly. So after the show, go to sleep. No more watching TV.
Well, after the show.
Well, no, not going to sleep, but no more shows after this. No more shows.
Yeah. Turn off the TV.
Doctor, have you heard of TrueHealth.com? They're supposed to customize.
Yeah.
But definitely don't work for them or anything. I've never tried them. It's supposed to be very expensive, like $300 or more a month, and they look at your psychiatric meds, and they come up with they have MDs that come up, allegedly, I've heard, with your own special natural.
And I haven't heard of that.
TrueHealth.com.
You know what, Bill, I haven't heard of that, but it sounds actually like a good idea. But you could probably do that with that doctor of yours that actually thinks that you can be off of this stuff. I mean, you can tailor it yourself, kind of like you've already started to do. But you can work with them. They're not going to. This company that you're talking about is not going to do anything magical. They're just going to give you attention. And we don't have as doctors time to give the kind of time you need. But if you got a doctor who believes in you, say, look, I want you to book me a 20-minute appointment, not a 3-minute appointment, a 20-minute appointment to talk about this, maybe just for 2 months every second week. And I want to do this. You can tailor make it yourself. I mean, they're not going to do anything fancy. They're just going to give you the time that you're going to have to otherwise insist for.
Right.
Well, they pitch that they have a whole database of people with whatever problems, and then they start to learn from that what pharma meds can be complemented with what natural ones, and they have MDs that work there to tailor your custom vitamin solution that helps people get off meds.
Is this a company that's in Toronto?
I think they're in Vancouver. There was actually a big story about them years ago, and a lawyer named Sean Buckley defended them because they were taken off the shelves, and it was claimed that some people actually killed themselves when they were taken off the shelves, and they're only natural vitamins.
Okay.
And if you were Google Sean Buckley, a lawyer who works for the National Health Products Protection Association, .org, it was a big story at the time, and he got it rectified so that they could sell their natural vitamins.
Okay. Well, okay. So it sounds like they're trying to sell something, and maybe that's where the $300 comes in. You don't need to do that, Bill. You can do this with your family doctor. You don't need any fancy meds. You just got to get time and somebody to actually help you with a taper process.
Okay, great.
Yeah.
Well, thank you, Doctor.
Yeah.
Thank you.
Thank you.
Thank you. Bill, thank you for calling. We hope we answered your question this evening. Do you have a story about your medications? Do you think you're addicted or just become really tolerant to them? Give us a shout this evening. You know, I'd like to, we do have a caller, Alma Marie. Let me say that again. Alma Marie. We have her waiting, but I want to talk with you hopefully a little bit later with respect to what he was talking about, the natural remedies, you know, herbs and stuff like that. Are there some of those that might be safer or better? But we can, you know, think about that.
Sure.
Alma Marie, thanks so much for calling. How are you doing this evening?
I'm good.
Great. What's your concern or your question or story?
Okay. My question is, there's people out there, doctors out there that are overly prescribing people, correct?
Yeah.
Now, why are they not being investigated?
Oh,
and
well,
there's people that are actually getting the extra medication and selling them. They're the ones that are going to jail.
Yeah. Well, that's a very good question, Elma. That's a very good question. And I can say to you that the process of nailing a doctor is exceptionally difficult to do and takes a few years. I mean, first of all, you got to flag the person, and then you got to. I mean, the patient's got to complain, or I mean, first of all, essentially what it is, it's the College of Physicians and Surgeons in Ontario will take a complaint, or something will have twigged them. Okay, this is a guy who's only prescribing or over prescribing on opiates or sleeping pills, and then they've got to actually do an investigation. And that investigation then can be not appealed, but the doctor himself has a right to state their case.
All right.
And that whole process can actually take 2 to 3 years. I mean, that's just for one doctor.
Wow.
I mean, there are actually a few doctors out there, and you know, they have been eventually approached, but it takes a while. It takes a while. You're right, Alma Marie.
All right. Well, that was my only question. And holla, Dr. Tarman.
Hello.
All right.
Thank you.
Thanks for calling, Alma Marie.
Yeah.
Do you think you're addicted to your prescription drugs? Give us a call and let us know. Or are you taking them safely? Whatever concern you have, give us a call this evening. But yeah, going back to then, are there the
natural remedies?
The natural remedies,
Okay, but Bev,
the alternative medicines, are those?
But you know what, Bev? I'm a doctor, and I'm prescribed to use my prescription pad.
I know you
and
are.
You're going to ask me a question I don't know the answer to because I don't know what herbs to suggest. I mean, I know that I'm doing a big talk on sleep hygiene because I know how important it is. I will say that the values of melatonin, although we don't actually know what the long-term consequences of that are either, it's much better really if you can just find a way to get your own body to do its own natural rhythm.
Right.
But we do so much to get in the way of that.
It's so true.
Yeah.
And even for things like depression and you know, anxiety and all that, you know, finding that root cause.
Yes.
And getting rid of that thing in your life, or you know, taking the steps to alleviate whatever because I read somewhere where most of our illnesses are, you know, from psychological stuff that's going on in our lives and then manifests physically.
Yes, that's right. That's right. That's absolutely true.
So instead of masking it with a painkiller or a depressant, antidepressant, get to that root cause.
Yes, if you can. Yes.
Yes,
I mean, I have learned to be a little bit more compassionate in the sense that sometimes a person's not able to get to the root cause.
Right.
But I mean, it's one of those things where it's so hard because if you do mask it, then you know the person is in a difficult scenario, like they should be leaving their job because they hate their job.
Exactly.
And I can give them an antidepressant and an anti-anxiety medication so that they're not hating their job while they're at work. But that means they're not going to get out of that job.
Exactly. And also means that I mean, no drug comes without side effects.
Right. Absolutely. That's right.
So you're giving them something else that's masking, but also eating away at them at the same time.
Yes. But then sometimes people just simply can't leave their job. Like they're stuck in a situation where they just simply can't. And then
But are there other things we could be prescribing, like go, exercise, get a hobby, something else you really enjoy, find something else, as opposed to giving them these kinds of things that are healing them slowly.
But I'm gonna. Can
I say that? I said that.
No, you can say. Well, no, it does. And let me just say that I remember asking a patient, and here's something. Maybe callers, if you want to think about challenging me on this. I remember once asking a young guy, he was maybe 20 years old. I said, okay, you're taking this medication. Why don't you instead do exercise and do things like he wanted to become a computer, like somebody who helps fix computers for people or IT, basically IT. And he said, well, yeah, but it's easier to take a medication. Why don't I just take the medication?
I know, that's the thing with many people. And doctors have said that they prescribe things because they don't feel people will really take the time to do the other things that they could be doing instead.
Sure. And the other thing is doctors will prescribe medication because it's just a lot easier. I mean, I got 3 minutes for you, and I can either give you the medication in 3 minutes and tell you quickly the side effects, or I can spend the next 20 minutes telling you, no, I don't want to give you this. I don't have 20 minutes. Here's the medication. Next, please.
Wow. And so our whole system is just flawed.
Well,
from the 3 minutes on, it's flawed.
It's biased towards prescribing medication. And that's where we get into prescription abuse because it's already biased towards prescribing, and then not everybody, it's probably only about 10% of the population will end up abusing it. Actually, we've got a statistic here.
We do have stats.
3% actually have abused their medication.
Right.
Yeah.
But there was another stat that we had that was really mind-blowing. Where is it? I can't find it, but it's like 23%, yes. 23% of Canadian population is on psychoactive drugs.
Yeah, that's right.
A quarter of our population.
A quarter of our population is either on an antidepressant or an anti-anxiety medication or an antipsychotic medication. Yeah, we are a very medicated society.
That's mind-blowing.
Yes, it is. Mind-blowing.
No pun intended.
Yes,
no pun intended.
No pun intended.
My goodness me.
So, like I said, we're a very medicated society.
My goodness. Viewers, do you have any questions or stories or concerns about your medications? Are you taking it safely? Do you think you might be addicted? Do you think you might be dependent? Give us a call and let us know. I want to just say, going back to one of the callers who was talking about a lady who was seeking drugs from elsewhere.
Oh, yes.
Another stat where 70% of prescriptions are given by friends and relatives.
That's
so
right.
not even by the doctor.
That's right.
But just you're getting it from 70%.
Yeah,
that's
so
huge.
That's right. So like 30 to 40% of our meds that are being abused are actually given to us by our doctors, but we're getting the rest from other sources, either through friends and family or from the street.
Oh, goodness me.
Yeah.
I think we have a caller. Do we have a caller, Rosalie?
That's me. Hi.
Rosalie, how are you doing?
I'm great, thank you.
Wonderful. What's your question, concern, or story?
Well, first of all, I'm calling because I really thank very much the doctor in bringing this to the attention of the public. And I am vice chair of a foundation called the International Schizophrenia Foundation, which is our mission is to promote the wide acceptance and use of orthomolecular treatment of mental illnesses, including schizophrenia.
Do you want to, before you ask your question, can you tell the audience what that means?
Orthomolecular is the right molecule for your body. And now it's safe to use with medication. This was developed by psychiatrists and doctors, and we give doctor training programs on how to integrative medicine and how to use nutrients along with medication.
Right.
And these courses are they've been accredited by the College of Physicians and Family.
Can you give some example of orthomolecular medication or
it's
nutrients?
Nutrients that may be specific. You can get tested. You can go to your doctor and ask your doctor, am I deficient in B12?
Okay.
Am I deficient in vitamin D? These are known to be depressed. If you are low in these things, you can get depressed.
Or even omega-3.
Omega-3s.
So are those actually considered orthomolecular nutrients?
It's anything it's just a fancy word for using nutrients that are natural to the body.
That's what you were asking me about, Bev. Thank you for calling us. This is great.
It was started in it's been going on for about 80, 90 years, but actually orthomolecular medicine began in the early 50s, and when pioneering psychiatrist Abraham Hoffer and his colleagues did lots of research on niacin and
niacin, which is used for alcoholism as well,
which has been shown to help the heart and to help a lot of things because nutrients help so many processes in the body, not just one. And but it did make a very big difference for those with schizophrenia.
Well, actually, what kind of drug would be used for? Nutrient would be used for schizophrenia? Because normally what we would do is give Seroquel.
It depends on the person, but it was found that niacin was, or niacinamide. Now, niacin in itself has a flush. I'm almost a nutritionist, and so and I've worked with a psychiatrist who uses this in her practice.
Oh, really?
Yeah, so I've been involved in this for about 20 years, 24 years, and but it's looking at your diet. Some people are gluten intolerant. Some people.
So
there's some.
Rosalie, let me ask you a question. If you were taking a drug like our previous caller of Seroquel of 800 milligrams, and now he's on 400 milligrams, would using one of your orthomolecular nutrients help that person get down and to possibly get off of their Seroquel?
They may not be able to get off. It depends on the person.
Yes.
And it depends on how long they've been ill.
Yes.
But most people can get better. I mean, if people have tardive dyskinesia, if they have the shakes very often, it's because of the medications that cause nutrient losses in the body. So if you would take, certain nutrients such as that they would replace what the medications unfortunately sometimes will.
Right. So you could counteract some of those negative consequences.
Nutrients like manganese, there's vitamin E. There's just different things, omega-3s. But so and it should be done under the direction of a practitioner who knows how to use these nutrients. You may not take enough. You might be taking too much. And it's good to get. It's really helpful to be tested.
Is it?
Again, we have a presentation on this coming weekend. It's integrative medicine for children's mental health and evidence-based orthomolecular approach. And it's being presented by Dr. John Ganache, MD, CCFP. And he is speaking, and he's speaking in
Rosalie. Rosalie, I'm sorry, I'm going to have to cut in just now. We do have to go to break, but we want you to stay on the line so we can talk with you after. We'll be right back with more help on Addictions Unplugged. Welcome back to Addictions Unplugged. Today we're discussing and taking your questions on addiction to prescription drugs. And we have Rosalie on the phone from before the break. Rosalie, so the orthomolecular, love that. It sounds so highfalutin there. But yet nutrition, I'm a dietitian myself and know exactly what you're talking about. That's fantastic stuff, using that as opposed to or in conjunction with.
So you know what, it's great as adjunct. We never would say people should stop their medication.
Not without the doctor's.
No, and it has to be done under a doctor's care.
Absolutely.
And of course, that's not responsible to do that. And you can to stop abruptly could be very difficult. Dangerous.
And
dangerous. We would never say that. But the addition of certain nutrients cannot harm people if it's given in the right context.
So thanks, Rosalie.
Great,
but
Rosalie.
I'd like people to check on to isfmentalhealth.org. ISF as in Frank, mentalhealth.org. mindfulcharity.org. And we have a branch of an arm of the organization called mindfulcharity.ca for children.
Okay. Thank you very much. Thank you very much.
Okay. Excellent. Yeah. Thank you, Rosalie, for all that great information. And, you know, we got from some more stats here. 1 in 6 Canadians over 15, so they're starting early, take opioid pain meds within a 12-month period. 1 in 10 use sedatives. 1% of Canadians use stimulants. So a lot of us are taking a lot of things.
That's right.
And, you know, working in a hospital and in long-term care, I see people with just a long list of medications that they're, and you start off taking one, and then you have to take another one to offset that one, and so on and so on. So you're taking 20 meds.
You know, it used to be said in the geriatric field, which is, you know, for elderly people, that the first thing that a family doctor should do is get the person to bring in their lunch bag of meds and start chucking them.
Exactly. Like, and I like the lunch bag thing.
Yeah. Do you really need this? Do you really need? And then you'll find that a lot of their cognitive impairment clears. But this is not really, I mean, you know, our talk today is not really just, you know, being too down. I mean, medication can be very useful.
Can be, yes.
But the thing about this talk today, which is about prescription drug abuse, is that it can also be abused.
Right.
And that's where we worry about it, because, like you said, 70%, like one, you know, it's in your house, it's in your medicine cabinet, and somebody is checking that medicine cabinet, and you know, these things can be abused.
Absolutely.
And we have a major narcotic epidemic right now of OxyContin or other types of opiates. Now it's actually fentanyl as well. And these are prescription medication that somebody was prescribed. But the people who are using them were not the people that were prescribed these medications.
That's crazy. That's crazy.
Yeah.
Another thing I find really crazy is that children, children as young as 5 years old are being prescribed Ritalin or other things like that for their ADHD.
Yeah.
You know, that's so
you know,
unsettling.
And even if you agree that that child needs it because of their ADHD, maybe they do, but where we see the actual abuse of that is where the child or the teenager, which is more, I mean, you're right, it is starting to show up in younger
absolutely.
kids. But in teenagers, they use it, but then they don't use it appropriately. They take too much of it, or they snort it, they do something so that it's not being used appropriately. And, you know, when it becomes part of your peer culture to do that, we've got prescription drug abuse here. And that's potentially, I mean, like I said, youth are 5 times more likely to report harm due to drug use. Yeah.
That's our young people. Those are the people who are going to be leading tomorrow. And
yes. And the other thing I really want to say for people, this is like a warning sign, is that sometimes prescription medication is actually safe to use, but if you're mixing it with another prescription medication or with alcohol, it's no longer safe.
Right.
And you know, one of the best ways to die is to take your proper amount of sleeping pill, but then drink far too much, because the alcohol and the sleeping pills have not just a cumulative, but an actually double effect. So then, I mean, that's not good. So it's you know, you have to be really careful.
This prescription drug thing, and you know what's really interesting when you see those commercials for particular drugs, and half the commercial is about the side effects.
Yes, that's
you know, they whip through all these side effects.
Yes.
It's like, really?
Yeah.
Could we not do something like eating more healthy, getting more exercise? This is my, you know, my this is what I teach and triumph. Absolutely. Can we not start there first, and then if these things don't help, then we can go down the other route. But as you said, doctors have 30 seconds.
Yeah.
I mean, 3 minutes. 3 minutes.
3 to 5 minutes. Virtually,
and they don't have that kind of time.
Yeah, that's right. Yes, and also, you know, there's what we call that standard of practice. You know, doctors are expected to prescribe, and they are also expected to talk about diet and sleep and exercise, and they do. But you know, it's like that 20-year-old boy that I asked. Says, no, it's easier to do that than to do the exercise.
Oh, absolutely.
And you know, that in itself is a whole talk. But then we have the whole abuse. It's there. It's accessible, and then people end up abusing it, especially if they're already addicted to something else.
Right. You know, for me, my mantra is take charge of your own health. You know, and that kind of goes to what you're saying about the power, you know.
Yeah.
What is it that you say?
Power is ours.
So take back that power.
That's right.
Take charge of your own health.
Yes, that's right.
You know, instead of running to the doctor. The doctors are fantastic, but for every little thing, take charge, get some exercise, get some sunshine, eat properly, drink the water, all of these kind of things.
Yes.
As we're closing, I think we got like 30 seconds left, but that's my charge to everybody.
Okay. And you know, I do want to say that there is times when medication is appropriate, but the abuse potential is it's never appropriate, and you just have to be really careful. Don't take more than you're supposed to take. Follow your doctor. Don't try to do something on your own. Those are all markers that things are dangerous. And don't take somebody else's medication.
Exactly.
Yes.
Fantastic. Well, we are out of time. On behalf of my co-host, Dr. Vera Tarman, and myself, thank you so much for watching the show. Callers, thank you for being so courageous and calling us this evening. Thanks for watching.